So here is the answer to the quiz posted on the 12th of June. Now this is a slightly advanced quiz, but an easy quiz if you sort of read about it. So this is a 66-year-old male with a single hyperpigmented scaly plaque on the right groin of 3 months duration. He complained of increasing in size since 1 month, no regional lymphadenopathy, but one significant part of the history was that he underwent thyroidectomy 5 years back for papillary carcinoma of the thyroid. Okay, so this is the histological picture. You can see here that on low part, you see here that the epidermis is hyperplastic. You can see a bit of acanthosis, some compact hyperkeratosis here, more basket weave type here. Yeah, you can see the acanthosis, the epidermis is thickened. No particular pattern to it. It's not quite psoriasiform. There's no elongation of wetty ridges in a bulbous pattern with clubbing. It is just irregular hyperplasia. But what is also prominent is a dense infiltrate here. It is a lichenoid infiltrate, band-like, with pigment incontinence, which you can make out here as well. Okay, but what is also prominent are these sort of clear cells in the epidermis. Even on low power, this is called a buckshot pattern. So if you fire pellets from a gun and the pellets are scattered, they're scattered in the epidermis. This is called a buckshot pattern, and this is typically seen in Pagetoid change, it's in Paget's disease, whether it's primary, extramammary, or Pagetoid spread that we may see in Bowen's disease, melanoma. So just because you're seeing a buckshot pattern, it does not necessarily imply Paget's, but there are other features of Paget's in this particular case, which I will explain in a second. So just illustrating the sort of lichenoid change, and you can see, these sort of Pagetoid cells. Now, what do I mean by Pagetoid? Pagetoid refers to clear cells, the large cells with clear cytoplasm or pale eosinophilic cytoplasm, with this sort of halo separating these cells from the surrounding keratinocytes. Okay, you can see a clear halo, this space. So this is what we call a Pagetoid cell. Okay, and you can see the halo here even on low power. Now the higher power images are also shown here. So you can see here the higher power images. You can see this halo here. Nice, clear cytoplasm, much larger than the surrounding keratinocytes you can make out. So this is the keratinocyte. Sometimes you see a granular cytoplasm, and this perinuclear halo is quite nicely represented. Now, what you can also, sometimes you may see epidermal hyperplasia as well associated with this. Sometimes you may see a pincus type fibroepithelioma pattern of hyperplasia as well, which can be quite confusing. So here, this is another picture. Obviously, this is a much higher power of another image of another section, and you can see the Pagetoid cells here as well, much larger cells. Now, you can probably make out an attempt to duct formation. So this is a clue to Paget cells where there is some attempt to duct formation, which you can see on H&E. You can make this out here. Now, why do I say duct formation? Because Paget cells are supposed to be derived from the type of adenocarcinoma, supposed to be derived from the in sort of primary Paget's disease of the breast, for example. They're derived from the intraductal, it's basically an intraepidermal spread of ductal carcinoma of the breast. In extramammary Paget's, it is spread from vulval adenocarcinoma, or that's in the primary that's in the secondary type of extramammary Paget's. But however, there is a primary pattern which may be actually derived from the sweat glands, the sweat ducts rather. Okay, so these extramammary Paget's is common in places where there are a lot of apocrine glands. So it can be sweat or apocrine actually. Apocrine is actually more common. So axillae, you may find them, groin area, vulva. These are the places where you may find extramammary Paget's disease. There is an equine variant as well, which is derived from the sweat glands. Okay. Now, when you're seeing extramammary Paget's, the first thing, now this is a groin area, the first thing you need to determine whether it's primary, i.e. derived from the skin, apocrine or equine glands, or whether it's secondary, whether it's spread from an underlying adenocarcinoma of the vulva, of the rectum, of the uroepithelial gland, or uroepithelial tract, etc., or the prostate even sometimes. Now, this is determined by IHC stains. On H&E alone, it's difficult to determine unless you see, unless you're seeing some underlying focus in the dermis. Now, let's see these questions first. So this is an inflammatory condition. This is a neoplastic condition. So this is a malignant condition. Bone marrow examination has no role actually. A CT scan of the abdomen pelvis is usually necessary because though IHC may give you some clue, you still have to do the screening to make sure there's no underlying malignancy, no underlying adenocarcinoma. Now, so what special stains have we done? Now, you can do a PASD stain or you can do a mucin stain, which may show you mucin within these within the cytoplasm of these glands. Now, that does not necessarily tell you the origin of the tumor. So I didn't do it in this case because it's more academic. I know that this is Paget's disease, so I didn't quite feel the need for doing a mucin stain. So CK20 is a very important stain if it's positive. Now CK20 you can see is staining some cells here. You can see these are surrounding keratinocytes. The keratinocytes have not taken up the stain, but the cells within the tumor, these are the tumor cells. Some of them have taken up the stain, but it's very faint. Okay, this is not a dark stain. Now, if CK20 is markedly positive, it is indicative of an underlying or indicative of secondary extramammary Paget's disease, i.e. spread from an underlying adenocarcinoma. But if the CK20 is negative, completely negative, then it's indicative of primary extramammary Paget's. In this case, it's faintly positive, so it's still indicative of primary extramammary, but I have reported that secondary needs to be ruled out because it seems to be faintly positive. CEA is a characteristic marker, CEA and EMA. They are positive in Paget's disease, and that is the marker that confirms the diagnosis that this is Paget's. There are other tumors that can mimic Paget's, like for example melanoma. You can have Pagetoid Bowen's disease, which can also mimic it. In such a case, CEA is negative. Similarly, P63 is a very important marker. It is negative in Paget's disease. Now, you may think that this is positive, but this P63 is actually staining the surrounding keratinocytes, which have become a bit activated. You can see that these are tumor cells. Okay, the tumor cells itself are negative. You can make out here, this is a tumor nodule. These Pagetoid cells are negative. P63 is really only marking the smaller nuclei, which are the keratinocytes. The larger nuclei, vesicular nuclei with surrounding surrounding sort of eosinophilic cytoplasm, are negative for P63. Okay, so it's easy to get confused with this. But if P63 is positive, then it indicates Bowen's disease. Now, the links I've posted along with the answers in the quiz are self-explanatory if you want to read more about this. Okay, so P63 is usually positive in Pagetoid Bowen's disease is true. Negative in primary vulvar Paget's disease is true again. CA is positive in papillary thyroid carcinoma is actually false. It's usually positive in medullary thyroid carcinoma. It's negative in papillary thyroid carcinoma. CK20 is positive in secondary Paget's disease is true. CK20 is positive in Langerhans cells is false. Now, I've put in Langerhans cells because Langerhans cell histiocytosis can sometimes resemble Paget's disease, and that can be a differential diagnosis. All right. So the final diagnosis here is extramammary Paget's, primary rather than secondary. I have not put in the differentiation here because it's a bit too advanced for people who are still learning dermatology, but learning dermatopathology. But I think it's I'll provide the explanation in the video here. So all these are definitely valid differentials. Metastatic papillary thyroid carcinoma, which we've excluded based on the positive CEA. Then malignant melanoma, we've not really excluded because I've not done an S100. But then CEA is positive, which would be, which excludes melanoma anyway, because we've confirmed that this is an adenocarcinoma origin, and hence it's CEA positive. Langerhans cell cytosis won't stain for any of the markers I've just described. It is S100 and CD1A positive, but I didn't feel need to exclude it because I've confirmed the diagnosis of Paget's disease in this case. All right, I hope you enjoyed the quiz. Thank you very much.